Welcome back to the deep dive. Today we're navigating a really critical and often, well, emotional landscape, the health of our children. Specifically, we're looking at the intricate workings of their hearts. We're diving into alterations of cardiovascular function in children, and we're pulling the most important nuggets, the key takeaways from Chapter 27 of Understanding Pathophysiology, 7th edition.
Right.
Our mission really is to cut through the complexity. We want to equip you with the essential insights into both congenital and acquired heart conditions in kids.
Yeah, make it accessible.
Exactly.
Yeah.
Think of this as your shortcut to understand the core mechanisms, the clinical pictures, even if you don't have the book right in front of you. It's a profound journey because, as the chapter points out, congenital heart disease, CHD, it isn't just common.
No, not at all.
It's the most frequent heart condition present at birth and a leading cause of death in the first year of life.
Yeah.
Second only to prematurity.
It really drives home how vital these tiny hearts are.
It really does.
And, while that statistic is sobering, what's truly empowering is the monumental progress we've actually seen.
Right.
Thanks to incredible advancements, things like fetal echocardiography for super early detection, groundbreaking interventional procedures using catheters.
Right, less invasive.
Exactly. And highly refined surgical repairs. The diagnosis and management of CHD are, constantly improving.
That's encouraging.
Yeah, these aren't just tiny changes. They're really transforming outcomes for children. But acquired heart diseases in children, they still present a unique set of challenges.
Different ballgame.
Kind of. They often demand different approaches and, ongoing research to really optimize treatment and long-term care.
Okay, let's start at the very beginning then, with congenital heart disease, CHD. Literally, heart disease present since birth. It's more prevalent than many people realize, right?
Yeah.
Affecting about 4 to 8 out of every 11 live births.
That's the range, yeah.
Now, understanding why these conditions happen,
Yeah.
it isn't always straightforward, is it? It's often a complex mix, like genetics and environmental stuff.
That's absolutely right. It's rarely just one single cause.
Right.
What's truly insightful, I think, is how seemingly unrelated maternal factors, things like infections, metabolic issues, even some medications, can profoundly impact how that fetal heart develops. For instance, certain infections like rubella during pregnancy, well-known culprits, they're linked to defects like patent ductus arteriosus.
Okay.
But it's not just infections. Maternal metabolic disorders, especially uncontrolled diabetes, can raise the risk for things like ventricular septal defects or VSDs, or even cardiomegaly and enlarged heart.
Wow.
And yeah, unfortunately, exposure to certain drugs like alcohol or even some anticonvulsants like phenytoin can disrupt normal heart formation too.
It's a powerful reminder, isn't it, how delicate fetal development is.
Absolutely. Very susceptible to those external influences.
So, okay, on one hand, we have these external environmental factors. But the chapter also points to genetics. How significant are those?
Genetics definitely play a substantial role. Chromosomal defects alone, they account for about 6% of CHD cases.
Okay, like what kind of conditions?
Well, think of Down syndrome, trisomy 21. Children with Down syndrome have a much higher incidence of atrioventricular septal defects, AVSDs, and also VSDs. And similarly, Turner syndrome, which affects females, is often associated with coarctation of the aorta COA and aortic stenosis, or AS.
I see.
But, and this is really the crucial takeaway, for most of these defects, the cause isn't purely genetic or purely environmental, it's multifactorial.
Multifactorial.
Meaning it's a complex dance, between an individual's genetic makeup and these environmental triggers. It's rarely one single smoking gun, usually a combination of vulnerabilities.
That multifactorial piece really highlights the complexity.
Right.
So with such a wide range of defects, how do clinicians even start to categorize them to make sense of what's actually going on inside the heart?
Yeah, that's a great question. And what's fascinating here is that despite all the different anatomical variations, the classification of CHD really boils down to blood flow patterns.
Okay. Blood flow.
Exactly. The chapter breaks them down nicely into 4 main categories. 1, defects that increase blood flow to the lungs. 2, obstructive defects, things blocking blood flow out of the ventricles. 3, defects that decrease blood flow to the lungs. 4, And finally, defects causing mixed blood flow, where oxygenated and unoxygenated blood get jumbled together.
Got it. 4 main types based on flow.
Right. And to really get these, we need to quickly talk about shunting.
Okay, shunting.
Yeah. So normally, your heart's left and right sides work like two separate pumps, right? Right side pumps to the lungs, left side pumps to the body. A shunt is just an abnormal path, like a detour for blood between those systems.
Ah, okay, like a leak.
Kind of. If blood takes a shortcut from the left side to the right side, say, from the high-pressure left ventricle to the lower-pressure right ventricle through a hole.
It's like a VSD.
Exactly, like a VSD. That's a left-to-right shunt. This sends extra blood to the lungs. Now, because this blood still goes to the lungs eventually to pick up oxygen, it doesn't usually cause cyanosis, that bluish skin color.
So, asiatic. No blue tint?
Precisely, acyanotic defects. But if blood shunts the other way, from the right side to the left side.
Skipping the lungs.
Right. Bypassing the lungs entirely, sending that unoxygenated blood straight out to the body, that is a right-to-left shunt. This leads to less oxygen in the tissues, causing cyanosis.
Making the baby look blue, so cyanotic defects.
You got it. Cyanotic. Understanding these two basic flow patterns, left to right versus right to left, is really the key to figuring out what each specific defect does.
That clarity on shunting really helps connect the dots. Okay, so building on that, let's put some names to these conditions. Let's look at some common CHDs, starting with those that increase pulmonary blood flow, the asionic ones.
Excellent. Yeah, the classic examples here are defects that create that left-to-right shunt, basically flooding the lung circulation. Let's start with patent ductus arteriosus, or PDA. PDA. Okay. So imagine this vital shortcut vessel in the fetus, the ductus arteriosus, connecting the aorta and the pulmonary artery. It lets blood bypass the lungs before birth.
Right, because the baby isn't breathing air yet.
Exactly. After birth, this ductus should normally close up pretty quickly, within hours or days. When it fails to close when it stays patent, blood keeps shunting from the high-pressure aorta back into the lower-pressure pulmonary artery.
So extra blood to the lungs, continuously.
Continuously. Picture it like a leaky pipe sending oxygenated blood back for another trip to the lungs. Infants might show signs like fast breathing, getting tired easily, and often have this very characteristic, continuous, machinery-like murmur.
Machinery-like?
Yeah, it's quite distinct. Then we have atrial septal defects, ASD, and ventricular septal defects, VSD.
Holes in the heart walls.
Essentially, yes, abnormal openings in the septum, the wall dividing either the atria, ASD, or the ventricles, VSD. And VSD is actually the most common congenital heart defect overall.
The most common, wow.
Yep. In both ASD and VSD, blood takes that left to right path. Left atrium to right atrium in ASD, left ventricle to right ventricle in VSD. Both increase pulmonary blood flow.
Similar outcome, different location.
Right. Small ASDs might not cause many symptoms, but larger ones, and especially significant VSDs, can lead to major pulmonary overcirculation. And if that's not treated,
problems down the line.
Big problems. Potentially irreversible pulmonary hypertension. That's high blood pressure in the lungs, which can eventually cause the shunt to reverse. That's called Eisenmenger syndrome, leading to cyanosis later in life.
Serious stuff. And VSDs have a murmur too.
Often, yes. A loud, harsh murmur that you hear throughout the heartbeat's contraction phase. We call it holosystolic.
Okay, so PDA, ASD, VSD, all increasing flow to the lungs. Now, what about conditions where the issue isn't a leak, but more like a roadblock, the obstructive defects?
Right, these are also usually acyanotic, but the mechanism is different. Here, it's about narrowing, creating pressure buildup. A prime example is coarctation of the aorta, or COA.
Coarctation, like a pinching.
Exactly like a pinching. Imagine the aorta, the body's main artery, suddenly having this tight, localized narrowing, usually near where the arteries branch off to the head and arms.
Okay.
This bottleneck means blood pressure before the narrowing, so in the head and arms goes way up, but pressure after the narrowing in the lower body and legs drops significantly.
Ah, so high blood pressure in the arms, low in the legs.
Precisely. Clinically, you'd feel weak or even absent pulses in the legs, the femoral pulses, and find unexplained high blood pressure in the arms, especially in an older child.
And for newborns?
For newborns, it's critical. We might give a medication called prostaglandin E1 to keep that fetal ductus arteriosus open temporarily.
The PDA, why?
Because that PDA can provide a bypass route for blood to get around the coarctation and reach the lower body until surgery or a balloon angioplasty can fix the narrowing itself.
Clever workaround. What else is obstructive?
Well, there's aortic stenosis, ASS. This is a narrowing of the exit from the left ventricle. It could be the valve itself or just below or above it.
So the left ventricle struggles to pump blood out.
Exactly. It has to work incredibly hard against that resistance. This leads to the heart muscle thickening hypertrophy.
Makes sense.
And here's a really important practical point. The chapter highlights the "Did you know" box about endocarditis risk.
Endocarditis, infection of the heart lining.
Yes. Children with structural heart defects like AS, or many CHDs actually, are at higher risk for this serious infection, often seeded by bacteria from the mouth.
From the mouth.
Yeah, which is why maintaining really good dental hygiene, regular brushing, flossing becomes surprisingly critical for these kids. It helps reduce the bacteria that could potentially travel to the heart.
Wow, that's a connection I wouldn't have immediately made. Dental health impacting heart health.
It's vital preventive care for them.
Okay. Now let's pivot to the conditions that often present with that really visible sign, the cyanotic defects.
Yeah.
Specifically, those that decrease pulmonary blood flow. Not enough blood getting oxygenated.
Yes, and the absolute classic example, the poster child for this category, is tetralogy of Fallot, or TOF.
Tetralogy meaning four things.
Exactly. TOF is the most common cyanotic heart defect, and it involves four specific anatomical problems happening together. 1, a large VSD, ventricular septal defect. 2, pulmonic stenosis, narrowing of the pulmonary valve or outflow tract. 3, an overriding aorta. The aorta sits over both ventricles, straddling the VSD. 4, right ventricular hypertrophy. The right ventricle muscle thickens from pushing against the stenosis.
Okay, that's a complex picture. How does that cause cyanosis?
Well, picture it. You've got that narrow pulmonary outflow, the stenosis. It's hard for blood to get from the right ventricle to the lungs, but you've also got that big VSD, that hole.
So the blood takes the path of least resistance.
Precisely. It's easier for the deoxygenated blood in the right ventricle to shunt across the VSD directly into the left ventricle and then get pumped out to the body via the overriding aorta, bypassing the lungs.
Less blood to the lungs, more blue blood to the body.
Exactly. Less oxygenated blood reaches the tissues, causing that distinct cyanosis. Infants with TOF can have these sudden, frightening episodes of deep cyanosis called TET spells, often triggered by crying or feeding.
TET spells. What helps during those?
Instinctively, parents might put the baby in a knee-chest position. Squatting down does something similar for older kids.
How does that help?
It increases the resistance in the systemic arteries, the body's circulation. This makes it relatively harder for blood to shunt right to left across the VSD and encourages more blood to try and push through that narrowed pulmonary valve to the lungs. It's a temporary fix.
Fascinating mechanism. What's another cyanotic defect decreasing lung flow?
Another severe one is tricuspid atresia. Atresia means absent or not developed. So the tricuspid valve, the one between the right atrium and right ventricle, literally fails to form.
No path from right atrium to right ventricle.
None directly. So all the incoming deoxygenated blood is trapped in the right atrium. It has to find another way out, usually by flowing across an ASD or a PFO, patent foramen oval, into the left atrium.
So it mixes with the oxygenated blood coming back from the lungs.
Exactly. It mixes in the left atrium, then goes to the left ventricle, and then out to the body. This mixed, less oxygenated blood causes cyanosis right from birth. Survival often depends on other associated defects, like a VSD, to allow some blood to actually reach the lungs via the pulmonary artery, often from the left ventricle.
It's incredible how the body sometimes finds these compensatory pathways, even if they're not ideal.
It really is. Which leads us nicely into our final category of cyanotic conditions, the mixing defects, where oxygenated and deoxygenated blood are just kind of swirling together from the get-go.
Okay, mixing defects. What falls under this?
These are arguably some of the most complex and critically challenging defects. Take transposition of the great arteries, or TGA.
Transposition, like switched places.
Exactly. The plumbing is switched. The pulmonary artery arises from the left ventricle, and the aorta arises from the right ventricle.
Wait, so the aorta is sending blue blood to the body, and the pulmonary artery is sending red blood back to the lungs.
Precisely. You end up with two completely separate parallel circuits. The right side pumps blue blood to the body and gets blue blood back. The left side pumps red blood to the lungs and gets red blood back. Neither circuit is doing what it's supposed to for the whole system.
That sounds incompatible with life.
It is, unless there's some place for the blood to mix between the two circuits. You need an ASD or a VSD or a PDA, some connection that allows oxygenated blood to get to the body and deoxygenated blood to get to the lungs.
So those other defects become lifelines.
Absolutely crucial lifelines. Infants born with TGA but very limited mixing are profoundly cyanotic right at birth. The standard fix is a complex surgery called the arterial switch procedure, usually done in the first few weeks, where they literally cut and replumb the great arteries back to the correct ventricles.
Incredible surgery. What else involves mixing?
Okay, then there's total anomalous pulmonary venous connection, TAPVC.
That sounds complicated.
It is. Normally, the pulmonary veins bring oxygen-rich blood from the lungs back to the left atrium. In TAPVC, all those pulmonary veins drain somewhere else that connect abnormally to the right side of the circulation instead.
So all the red blood from the lungs goes back to the blue blood side.
Exactly. It mixes with the deoxygenated blood in the right atrium. Again, you absolutely need an ASD or PFO for some of that mixed blood to get over to the left side of the heart so it can be pumped out to the body. Depending on where the veins connect above the heart, at the heart, or below the heart, the severity can vary, but cyanosis is common early on.
Wow. Okay, what else?
Truncus arteriosus, TA. Here, during development, the single large vessel leaving the fetal heart fails to divide properly into the aorta and pulmonary artery.
So is this just one big pipe coming out?
One single arterial trunk, the truncus, that arises from the heart and then branches off to supply the body, the lungs, and the heart muscle itself. And there's always an associated VSD underneath it.
So blood from both ventricles mixes in that single trunk.
Yep. Leading to variable cyanosis and often way too much blood flow going to the lungs, which can cause heart failure symptoms.
Okay. One more complex one, I think.
Yes, and perhaps one of the most challenging. Hypoplastic left heart syndrome, or HLHS.
Hypoplastic meaning underdeveloped.
Severely underdeveloped. The entire left side of the heart, left atrium, mitral valve, left ventricle, aortic valve, and the ascending aorta are all tiny, non-functional, or even absent atretic.
So left side just doesn't work.
Essentially, no. Blood coming back from the lungs to the left atrium must cross through a PFO or ASD to get to the right atrium. It mixes with the blue blood there, goes to the right ventricle, which then becomes the main pumping chamber.
So the right ventricle pumps to both the lungs and the body.
Yes, it pumps blood out the pulmonary artery. Some goes to the lungs, but the blood flow for the entire body depends on getting through the patent ductus arteriosus, PDA, into the aorta.
So closing the PDA would be catastrophic.
Absolutely fatal. Newborns might look only mildly cyanotic at first while the PDA is wide open. But as it starts to close naturally, they deteriorate very rapidly into cardiovascular collapse. Without immediate intervention, starting with keeping the PDA open with medication and then a series of very complex stage surgeries over several years, well, it used to be uniformly fatal.
Just incredible what pediatric cardiac teams can manage now.
Truly remarkable ingenuity and skill.
Okay, what an amazing, if daunting, overview of those structural issues. But, all these problems, whether they're congenital or acquired later, can lead to that common endpoint, the heart just struggling to keep up. Let's talk about heart failure in children.
Right. A really common complication.
How does the chapter define it? Is it different from adults?
Fundamentally, the definition is the same. The heart can't pump enough blood to meet the body's metabolic needs. The cardiac output is insufficient.
And what are the main causes in kids? Still those CHDs.
Primarily, yes. Especially those congenital defects that cause a lot of extra blood flow, that pulmonary overcirculation we talked about, like big VSDs or PDAs or complex mixing lesions. Those really overload the heart quickly.
Okay. And how does it look in children? You mentioned earlier it presents differently than in adults.
Yes, this is really critical for anyone caring for children to grasp. The signs can be subtle. Instead of the classic swelling or shortness of breath you might see in an adult, we look for signs of impaired myocardial function.
Like what?
Like the heart beating too fast, persistently tachycardia, inappropriate sweating, especially during feeding or even at rest, decreased urine output, and crucially, poor feeding and failure to thrive.
Failure to thrive, not gaining weight.
Exactly. They just don't gain weight or grow properly despite seeming to take in calories. Their arms and legs might be pale and cool to the touch. Their pulses might feel weak. These are big red flags.
Okay, so that's the heart muscle struggling. What about congestion signs? Still different from adults.
Definitely. For pulmonary congestion, you'll see signs of difficulty breathing, rapid breathing, tachypnea, maybe visible effort like chest retractions or flaring nostrils. But here's the key insight from the chapter. Things like audible wheezing or crackles in the lungs, rales, which are common in adult heart failure, surprisingly rare in kids.
Interesting. And systemic congestion, like swelling.
For systemic venous congestion, you might see unexplained weight gain or find an enlarged liver, hepatomegaly, when the doctor examines the belly. But again, obvious swelling in the legs or feet, peripheral edema, or bulging neck veins, much less common in children than in adults.
So you really need to know these child-specific signs.
Absolutely vital for early diagnosis and getting treatment started.
Got it. Okay, let's shift gears completely now. We've covered conditions present at birth. What about heart issues that develop after birth? The acquired cardiovascular disorders.
Right. These are conditions that pop up later due to things like infections, autoimmune responses, genetic disorders manifesting later, or even environmental factors.
What are some key examples the chapter focuses on?
A major one with a very distinct clinical picture is Kawasaki disease, or KD.
Kawasaki, I've heard of that. It's an inflammation issue.
Exactly. It's an acute systemic vasculitis, meaning inflammation of blood vessels throughout the body. It tends to resolve on its own, it's self-limiting, but the big danger is its potential impact on the heart's own arteries.
The coronary arteries.
Yes. KD can cause aneurysms, dangerous swellings, or weak spots in the coronary arteries if it's not caught and treated promptly. It's actually the leading cause of acquired heart disease in children in developed countries.
Wow, who gets it?
It has a higher incidence in Japan and among children of Asian descent, but it occurs worldwide.
And how do you recognize it? You said distinct signs.
Very distinct. The key is recognizing a specific pattern of symptoms. The chapter highlights box 27.2, which lays out the diagnostic criteria. You need a persistent fever lasting at least 5 days.
5 days of fever. Okay.
Plus at least 4 of these 5 specific signs. 1, bilateral conjunctivitis, red eyes, but without thick pus. 2, changes in the mouth like a bright red strawberry tongue or red, dry, cracked lips. 3, changes in the hands and feet, redness, swelling, and later peeling of the skin on palms and soles. 4, a body rash. It can look like many things, so we call it polymorphous. 5, swollen lymph nodes in the neck, usually just one large one. Cervical lymphadenopathy.
Okay, fever plus 4 of those 5. That's specific.
It is. And recognizing it is crucial because prompt treatment with high-dose aspirin and intravenous immunoglobulin, IVUG, dramatically reduces the risk of those coronary artery aneurysms. It's really a race against time.
Makes sense. Okay, what else falls under acquired disorders?
Well, something we often think of as an adult problem, but is increasingly important in pediatrics: systemic hypertension or high blood pressure.
High blood pressure in kids.
Yes, and it's a growing concern. The definition itself is a bit different. In children, hypertension is defined based on percentiles for their specific age, sex, and height.
Not just a single number like a 120/80.
No. It's having systolic and/or diastolic blood pressure consistently above the 95th percentile for their peer group, measured properly on at least 3 separate occasions. The chapter has tables, like 27.4 and 27.5, that visually show how these normal values change dramatically as kids grow.
So you need those specific charts to diagnose it accurately.
It's absolutely essential. You can't just use adult cutoffs.
And what causes it in kids? Is it the same as adults' lifestyle? Diet?
It's different, especially in younger children. In infants and young kids, hypertension is much more likely to be secondary hypertension.
Secondary meaning there's another underlying cause.
Exactly. Often it's related to kidney problems, renal disease, congenital kidney defects, or sometimes cardiovascular issues themselves, like that coarctation of the aorta we talked about earlier, which causes high pressure in the upper body. Box 27.3 gives lots of examples.
Okay, but what about older kids?
That's where we see the concerning trend. In adolescents particularly, we're seeing more primary or essential hypertension, the kind without a single clear cause, more like adult hypertension.
And what's driving that?
The chapter points directly to the ongoing childhood obesity epidemic. There's a strong link. It's not just the blood pressure. It's tied to a whole cluster of cardiovascular risks, starting early signs of atherosclerosis, abnormal cholesterol levels.
So obesity is a major factor in acquired heart risk for kids, too.
A huge factor. It really hammers home the critical importance of promoting healthy eating and regular exercise right from the start. It's not just about weight, it's about long-term cardiovascular health.
That's a really critical, actionable takeaway for parents, for healthcare providers, for everyone. Okay, so as we wrap up this deep dive, what's the big picture here?
Well, our journey through this chapter, chapter 27, has really covered a huge spectrum, hasn't it? From those congenital defects present right at birth, the common VSD, all the way to the incredibly complex HLHS,
Right.
to these acquired disorders that develop later, like Kawasaki disease or childhood hypertension. I think the single biggest takeaway, the common thread, is just how crucial timely diagnosis and intervention are right across the board. Understanding these conditions, how they work, how they present, it directly shapes how we approach pediatric care. We're always striving for the best possible outcomes for these kids, both short-term and long-term.
And looking forward, I mean, this raises a really important question, doesn't it?
Mm-hmm.
As we keep advancing in areas like fetal medicine, genetics,
Mm-hmm.
and as we also grapple with these modern health challenges like obesity, how might we see prevention and treatment transform even more?
That's the exciting frontier, isn't it?
Yeah. Imagine, even earlier detection in utero, maybe more targeted therapies based on genetics, perhaps even down the line, things like gene editing, offering new hope for some of these really severe conditions.
Yes, definitely a future filled with potential. A truly thought-provoking vision for where pediatric cardiology could go.
Absolutely. Well, we really hope this deep dive has given you a clearer, more insightful handle on these critical topics from Chapter 27.
Hope it was helpful.
Thank you so much for joining us on this deep dive, and we absolutely encourage you to continue your learning journey.